Okay, good. Good morning again. Great you showed up again after the plenary of Marine. I hope you enjoyed your coffee and tea. And now we start working very hard this morning. We have very good presenters this morning about the key theme of this conference, cost and quality. So let's see what we can learn this morning. And I think I'm very happy with the four people that will present to us. It's Bernard Crump. He is the Chief Executive Officer of the National Health Service. And we have Gert Westert, and he is from the Netherlands. He is the professor in health services research, especially in quality improvement. And they, together with their partners, will introduce this theme to us. I propose that we will have their presentations, and Bernard will start. And after their presentation, we will have question and answers. And then we will start with the Dutch presenters, and we will finalize also with question and answers to them, and maybe we can combine it with all the four. So, David, yours.
Wim, thanks very much. Morning, everybody. It's a great pleasure to be with you. What I'm going to try and do over the next half an hour or so is talk a little bit about the context of improving cost and quality in the English NHS and give you some examples of progress, but also at the end, the caveats that there's still a huge amount to do. The context for our system is best described really by this graphic, which shows since the beginning of the NHS in 1948, the amount of money that we've spent on healthcare and the proportion of our gross domestic product we've spent on healthcare. And what you can see, taking out the effect of inflation, is how for a decade we've seen a dramatic increase and improvement in the spending in healthcare. But of course, what we haven't seen during that period is a similar improvement in the productivity of services. This is a graph from our Office of National Statistics. It's tried to do the very difficult thing of turning all of the outputs of healthcare, the activity and the improvements in quality and in health, into a single index of outputs. It also has put all of the costs into a single inputs index. And what it shows is that whilst outputs have improved, inputs have increased even at a greater rate, leading, if anything, to a small fall in productivity since 1995, during that period of enormous increase in investment. And of course, we also know that since the Lehman Brothers collapse, this is now 2 years ago, the chief executive of the NHS warning our system that we couldn't anticipate continuing to grow the resources for healthcare at the rate that we'd seen. And indeed, what this graphic shows is that over the next 5 years or so, the gap will grow between the resources that we think our healthcare system needed to continue to improve and the resources that will now be available because of the constraint on public finances in England. This is based on a report carried out in 2002, which tried to take a 20-year time horizon and identify the justifiable investment required in healthcare. It had 3 scenarios. And in the most optimistic scenario, our system would become more responsive, we'd become healthier as a population, and our healthcare system would become more engaged in improvement. But as you'll see, even in that most optimistic scenario, there will grow a gap over the next few years between the resources that report suggested we would need as our population grows more elderly and all of the challenges Maureen mentioned earlier will be faced, and the resources that we now anticipate will be available because of our constrained public finances, a gap which grows to between 15 and 20 billion pounds by 2014-15. And those of you from England will find that number very familiar. In England, we talk continually about the 20 to 15 billion pound productivity gap that we have to close. There won't be cuts in resources. Resources will grow each year, but demand and need will grow even faster. And in our current system, money passes from the Department of Health to primary care trusts who commission services from hospitals, from community services, and from primary care. And as in every system in the world, most of this resource eventually finds its way into the pay of clinical staff and others, and into the purchase of goods and services for healthcare. And in our system as it's currently arranged, government determines the rate of allocation, sets the tariff, which is the basis by which money flows from commissioners to providers of service. In our system, government also has a major role to play in pay bargaining and in managing the prices that we pay for certain goods and services, particularly drugs. And government has pulled all of those levers in order to try and help with the problem of finding improvements in productivity. In particular, has introduced a pay freeze for a period of time so that pay for healthcare workers will not increase. And the King's Fund and the Office of the King's Fund and their partners recently have calculated that pulling those changes means that the challenge may have been reduced a little, perhaps to an 11 to 14 billion pound challenge by the consequences of those changes. But the other way of putting that is that 11 to 14 billion pound productivity improvement has to happen locally in every healthcare system. To try and help, there's a wide range of national support for NHS organisations that are trying to tackle this challenge. And many of the people who are leading that national support are speaking at this conference on commissioning and pathways, on improving the efficiency of provider services, and on some of the system enablers. These slides will be available to you, and this link in the slides takes anyone who's interested to the websites which are the places to find all of the advice and outputs that these national supports are providing to our system. But it's still early days. The new reductions in tariff only kicked into our system last Friday on the 1st of April at the beginning of our new financial year. So what's the evidence and our experience of improving quality and cost in England? Well, I would say that this sums up our evidence, that we've got good evidence we can improve quality, and we've got evidence that some of that improvement can happen at the scale and pace that might be necessary for this challenge. But we have much more limited evidence that this will deliver cash releasing savings of the scale necessary, partly because most of this good evidence about quality improvement has accumulated in a decade in which resources for the system have been growing as steeply as I showed. And sometimes, when we've delivered improvements very quickly, we've had negative unintended consequences from some of those improvements. This graph shows all of the hospitals in England, only 6 months apart, and the proportion of patients seen in the A&E department and cared for within 4 hours. And what it shows in only a 6-month period is a dramatic move to the right, with a far higher percentage of people being seen within 4 hours. This was in response to a national targeted requirement to hit this target by a due date, but actually the process happened by the Modernisation Agency in England at the time, working with hospitals to help them introduce new ways of caring for patients in the A&E department, which would help hit this target. But there were some negative unintended consequences, and we've had to change the target, and there's a lot of clinical view that we hit the target, but we missed the point in terms of some of the issues that Maureen was referring to this morning. This graphic shows 19 hospitals, again, only 9 months apart, their caesarean section rates, working with one another and with us in the Institute on improving their caesarean section rates. Substantial improvements, not in all, but in many of these hospitals over a short period of time. And this graphic is taken from the BMJ of last year, a single hospital that worked on the implementation of a range of care bundles and showed statistically significant improvements in their hospital standardised mortality ratio in only a year, a controversial measure, admittedly, from the implementation of specific targeted quality improvements. Improvements in the targeted diagnoses exceeding those in other general diagnoses in the hospital. And we managed for the Department of Health a call for evidence in 2009. And we were able to find, from 200 submissions made from across the NHS in England, 70 examples, convincing examples, of improvements in quality which had led to reductions in cost, that met stringent criteria to be included in a national website, which is available for anyone to see. This is the site. If you receive this presentation electronically and click on this graphic, you'll be taken through to the site. It sits on part of NICE's website. And it has very, very good examples of programmes that are doing that very difficult thing of improving quality whilst reducing cost. At the Institute, we've been working on this problem for the 5 years of our existence. And I'm going to tell you a little bit with my colleague Valerie about some of the results that we've had from this experience. We've taken 3 complementary approaches from the outset. The first of those has been to increase for organisations the visibility of their productivity opportunity through the use of a national system of benchmarks. The second has been to find the ways that the highest performing organisations carry out common things in healthcare, common types of reason for people to be treated. Look at how that compares with organisations at the other end of the performance spectrum and see the extent to which we can put the way that the highest performing organisations do things into a series of guidance which can be adopted by everyone. And the third approach has been a series of programmes which are designed to help frontline staff see and eradicate waste in the way that their care is delivered. The first of the programmes are called the Better Care, Better Value Indicators. I won't speak about those today, though they're available if you're interested for any organisation in England. The second is our programme called High Volume Care. I'll say a bit more about this. And thirdly, what we call the Productive Series. So let's start with looking at the High Volume Care programme. So we constructed clinically led teams that visited the highest performing organisations and the least well performing organisations for common problems. In England, our payment system's based in hospitals on 620 or so healthcare resource groups, HRGs, but 50 of them make up half of all of the activity in hospitals. So we focused on some of those 50. Initially 8 clinical areas, subsequently we've gone on to look at another 11 clinical areas, common problems to be cared for in hospital. And our teams, who carried out structured visits to a range of hospitals, consulted with Royal Colleges and others, created a series of the things that drove the high performance of the highest performing organisations. And those were all codified into a series of guidance, ideal type care pathways. And now, gradually, our system is starting to introduce tariffs which are based on some of these high performing care pathways. In the case of knee replacement, for example, our highest performing organisations had an average length of stay of about 4.5 days. But what they focused on was not length of stay per se, it was optimising the period of mobilisation after surgery. And that was evident throughout the whole of their system, not just in the hospital element of care. They used criteria-based discharge. They focused on making sure all of the necessary resources, allied health professionals, the anaesthetic practice, even the bed space around the beds they used for these procedures was optimised to make sure patients could mobilise early. Our experience to date of these kind of systems is that we have very strong evidence that organisations can learn to adopt and adapt these ideal pathways and can improve their performance. We've extended this into a wide range of new clinical areas. But today I want to focus particularly on one example from the southwest part of England. In the southwest, the Strategic Health Authority decided to work with all of the orthopaedic units in their part of the country, working with us and with all of those units, bringing them together to focus on the elements of high performance. Only 3 days of input spread over a 4-month period. And they used the guidance that we'd produced about the elements that characterised high performance care. Now, this next graphic you don't need to see the detail of. What it shows is that before this intervention, most of the units were red or amber with only occasional green performance against these high-performing components of care. And after the implementation of this initiative, working together, supported by us, the vast majority of the performance turned green. What this graphic shows is the improvements in length of stay and throughput that happened over this period of time, such that this region of the country is now caring for the same volume of hip and knee replacement and fractured neck of femur through 280 fewer beds than they were before this intervention, liberating a very, very large amount of resource. And yet they still know that if they're to get to the performance across the piece of the highest performers, they have another 169 beds worth of productivity improvement to work on, and they are working on it. The productives are a series of approaches which put into the hands of people responsible for clinical care the tools to help them identify waste. It's a form of program inspired by the principles of Lean and Six Sigma, but it tends to have been co-produced with clinical professionals. We don't tend to use the language of Lean. And what we found is that these are programs which are very highly regarded and widely adopted by health professionals. The first of the programs was called the Productive Ward, and it's been available within the NHS for 2 to 2.5 years now. Last month, the data showed that now just approaching 60% of all wards in England have used this programme. The rest of the programmes for mental health wards, community hospitals and for the productive operating theatre and community services have been launched successively, so some of them are newer. And in April this month we'll launch the Productive General Practice programme for the first time. I'm going to talk a little bit about the evidence about the impact of the productive ward, and then Val will talk to you about her experience of using the productive operating theatre. We carried out recently a rapid impact assessment of the evidence about the impact of the use of the productive ward and its potential to contribute to our productivity challenge. This was an economic appraisal looking at quality outcomes, productivity and efficiency in a sample of trusts, all of which had 50% or more of their wards using the productive ward. The analysis overall showed that if these trusts are typical, the potential contribution from this programme across our system is around a £270 million improvement in productivity. We very carefully tried to make sure we captured the costs and the opportunity costs of the programme, as well as both the productivity and efficiency benefits, the financial benefits and the quality benefits. These graphics show a little bit of the evidence here. We looked at a group of trusts that were of different sizes and in different locations. And on average, you'll see that trusts had a benefit of cost which exceeded the costs of around, on average, £3 million per organisation, which together would result nationally in an improvement of around £270 million. But it's probably more instructive to look at some of the reasons. So what we found was that the mean improvement in the percentage of a nurse's time from before using this programme to afterwards, the percentage of their time that they spent in direct patient care was a mean improvement of nearly 20% of their working day now available for direct patient care. This translated into an average benefit of around £1.2 million for a hospital, but the hospitals were spending on average around £400,000 in the costs and the opportunity costs of implementing the scheme. But you'll see here the ranges were quite high. In particular, some hospitals were implementing this scheme with far less cost than others. And another way of looking at this, the mean benefit per ward was around £70,000 per ward, but the range was from 22 to 120,000. And roughly people got a payback of £8 for every pound they spent. Quite a lot of that was from reduced sickness absence amongst the nurses on these wards and the less of a reliance on temporary staff. There was also a contribution from reducing what in our system are called excess bed days, essentially an improvement in length of stay and also an improvement of readmissions. But in each of the categories, one of the characteristics was that some hospitals found far more benefit than others in the same category. This is just an example from one particular trust. This trust, therefore, spending around £500,000 in a one-off implementation of this programme and then a maintenance cost of around £70,000 a year. But they were getting benefits for the trust of around £1.3 million and for their commissioners a benefit of around £30,000. These numbers varied, but in each case there was a positive, significant return on investment. And this was all prior to the introduction of the new tariff arrangements, at a point when people were anticipating the need for new productivity but hadn't yet found themselves in the fiscal circumstances that we know are coming. Now, at that juncture, I'm going to pass over to Val, who's going to talk a little bit about their experience of working on improving operating theatre practice in her trust in Bristol.
Thank you, Bernard. So I wanted to share with you our experience of taking the productive operating theatre product and using it in our organisation. We started about 12 months ago, so still quite early days. Very much prior to launching the programme within the Trust, we brought together our project teams. We've got 26 theatres across 5 theatre suites, so we established project teams in each of those areas. We took the time ahead of the launch to develop a robust communication plan and to make sure that we had a proper project sharing forum for those 5 groups. Our information systems, which may be familiar to some of you, didn't quite speak to each other, so we took some time to think about the measurements we wanted to have as part of the programme as well. Post-launch, the second level down, our theatre teams across the 5 theatre suites got actively involved in implementing what within the programme is known as the foundation modules. So knowing how we're doing, putting meaningful measurement in each theatre suite, and making sure that when they understood their current performance across a number of domains, that they then used those numbers to drive improvement in those areas. Well-organised theatres around workplace organisation, and we've had some success around standardising our anaesthetic rooms and also operational status at a glance. So thinking about some easy, very basic and simple visual management tools we could put into the area. Alongside that, we did a safety climate survey so that we could assess the individual staff members' perception of safety in the theatres. And most of our effort was put on the scheduling module, particularly phase 1 of sessions and use. In terms of our own local context, we had spent 3 years prior to this actually building improvement capability within the Trust and had also successfully implemented the productive operating theatres. So in many ways, we were ready for the theatre programme when it was launched. Discussing productivity opportunities with our teams, they invariably talked about in-list productivity gains. So they would talk about the session starting on time, the turnaround time between patients and overruns. But we have a particular challenge in that we were running numerous what we call waiting list initiatives. So we had out of hours additionally funded sessions taking place at weekends and on Saturdays, and that really was something we needed to look at. Alongside that, we had a small number of surgeon and anaesthetist sessions that were funded in their job plans but hadn't been actually allocated to a defined slot in our weekly theatre schedule. So that was something we wanted to look at firstly. Our surgical division in 2009-10 spent £3.1 million on waiting list initiatives, and we aimed to eliminate that spend over 2 years. So 10-11, the target was 1.9 million, with the remainder for next year. When we embarked on the theatre programme, it was absolutely about supporting this cost improvement programme, and that was our main aim, to use the theatre programme as a vehicle to do that. So how are we doing? As at month 11, we achieved our 1.9 target, and our year-end projection is £2.1 million. This is primarily about improving our scheduling of our theatre sessions and making sure that we're using our existing funded capacity to the best possible way. There are a number of things that sit behind that around changing individual consultants' job plans and having team job planning as well, and a real drive that if an individual does drop a session, that we have a robust mechanism in place that somebody else picks it up. So going well within the year. This just demonstrates that with that, we knew we would still have to run waiting list initiatives this year again, but not to the magnitude at all has materialised that we thought it might do. So we're pretty confident that by the end of next year, we will have eliminated waiting list initiatives completely and deliver that £3.1 million saving. This is one of our hospitals, our eye hospital, BEH is Bristol Eye Hospital, didn't actually have the challenge with the session allocation and utilisation. So over the last year, they have focused on the actual in-list productivity. So you'll see from a very scarily low baseline of only 26% of the sessions starting on time, they're now at plus 95%, and hopefully we'll hold those gains. Some, again, silly things sit behind that, in that we would have unrealistic start times. We would have a surgeon in an overbooked outpatient clinic in the morning, expecting them to pitch up in theatres at 1:30, which was never a reality. So doing some good work on that. List starting on time is good for improved team communication and staff morale, but as we all know, the value-adding activity in theatres is the actual procedure time or touch time, which is the time when we're actually operating on patients. So have we managed to do anything there? Again, specific to the eye hospital at this stage, but they've managed to deliver a 12% improvement in actual procedure time that they're doing. A couple of things, again, very much around the emphasis on improved scheduling, but a couple of things that they've targeted. Some of you in the audience may be familiar with this, but one of our challenges in our eye hospital is that patients who are scheduled to have an operation do not attend on that day. We have become quite accepting of this as a way of not able to do anything about the capacity. So at pre-operative assessment, we have identified a number of patients, those under local anaesthetic, second cataract operations and laser surgery, who have agreed at their pre-op assessment that they would be willing to come in at short notice because they live quite close to the hospital. So if we contact a patient, if a patient can get to us by 10:30 on our morning list or by 2:30 on our afternoon list, we don't lose that slot. And since December, we've successfully managed to have 15 patients come through that way. That initiative, along with others around getting the 12% gain, means that 2 of our theatre sessions as of last month are closed down on Friday. We no longer need that capacity in the eye hospital because we've started to see these improvements. So if these are, I hope, a sense of we're making progress on our efficiency and productivity, I suppose what does that mean in terms of our safety side of things as well? So we have had a South-West programme around patient safety and quality, and lots of drive to get our compliance with a number of things like WHO surgical checklists, safety briefings, etc., improving, and we have managed to do that alongside it. So I hope evidence of frontline teams owning and rising to the challenge we have.
So, we're making some progress, but let's just be honest about how far we've got to go. We've got serious problems to address. The first is that we've, in many places, made quite a slow start. So despite the Chief Executive of the NHS warning us 2 years ago that these hard times were coming, the truth is they didn't really come until this last year. And not many organisations, in my experience, have been able to mend the roof while the sun was shining, as we would say. Secondly, there's a challenge about knowing how to take benefits that arise from quality improvement. We need systems that have understood and agreed how much of this benefit they need to take by releasing real cash for reinvestment in another part of the system. How much it's acceptable to do more work through the existing facilities, like for those of you who are here, the Cincinnati example this morning. Because if our commissioners don't need or can't afford that additional work, that's only a partial solution. How much we should be taking the benefits in terms of those aspects of quality and safety which do cost more, and how much in making life a bit easier for our staff, which can be a really important impact on morale. And we need people to have pretty explicit conversations about these things. Many of the greatest opportunities for improving the quality and productivity and safety of care arise between interfaces between part of our system. And there aren't very many places, there are some but not very many places in our experience, where all of the NHS organisations serving the same population are sitting down and working on this together. Not all systems have mature relationships, and indeed the new NHS reforms that we're experiencing in the UK are signalling competitive ways of improving quality, which may have an impact on the extent to which people work collaboratively. Sometimes it's hard to attribute improvements that are general, like improvements in length of stay, and say this proportion of this improvement was due to this quality improvement programme. We had to work on that very hard in our rapid impact assessment. Spread is a challenge everywhere, though I think by going from 2.5 years to 61% of wards in England using the productive ward is a signal that it is possible, if these programmes are compelling enough, to get people to use them quite quickly. We always have to think about sustainability. We have tools within the Institute specifically to try right from the outset to plan for sustainability and to maintain the gains. But overall, in a time of unprecedented challenge, I think there are some good examples of early successes at improvements in scale and pace, but many challenges to overcome. And as many of you know, those of you from England will know in particular, we're doing this at the time when our healthcare system is undergoing a series of changes which are described by the NHS Chief Exec as so big they can be seen from space. So I'm not in any way complacent about the challenge that we face, but thank you for listening to our experiences.
Okay, thank you very much, Bernard, and thank you for this presentation. I'm impressed about the quality improvements you have reached and the lean improvement that you have made, and still the way you try to get money out of the system. We have some time for questions, and if you think about it, maybe I start with one question. The cost as a driver, is that a hindrance for quality improvement, or can you use costs as a driver to improve quality in a positive way?
I think you can, but I think that it is also a question of how you frame the proposition, particularly framing the proposition to the clinical staff involved. When we began the work on the productive ward, it was before we knew that this challenge would arise. It was before the international global financial crisis. And our focus at that time was releasing time to care, because we knew that if that time was reinvested in the right clinical interventions, we'd improve the quality and safety of care. Now we've had to say that this programme is also one of the best and safest ways of meeting the financial challenge that the system faces. But sometimes for some of our staff that change in emphasis has been difficult for them to accept. But overall I'm encouraged that people see the scale of the financial challenge as so great that they know that change is inevitable. And what we also know is historically in England we've not done cost cutting well, and some of the cruder approaches to cost cutting would put quality at risk. So I still believe these programmes have an enormous amount to offer even in a time of fiscal difficulties.
Thank you. Somebody from the audience. Yeah. How do we do that? Yes.
I'm from England, Olu from Whitehaven.
Hello.
Hi. The problem we face is some of these changes need to be front-loaded. And the current financial climate is going to be very difficult to actually get the money to get it front-loaded. How do you think we should manage that? And following that, there is the aspect of, as well, of some of the experienced staff that we're going to need to make the changes are the ones being told they don't have jobs.
Yeah. I mean, for those of us who work in England, we know that this is a very, very challenging time. There are lots of creative ways, I think, of being able to bring human resource in particular to bear on some of these issues. We're working a lot, for example, with students and people in training who need, as part of their training, to be able to carry out quality improvement work and trying to get some of that work focused on these pressing problems. But of course, it's not at all easy. And I think I'm coming to the view that there will have to be a point, because the scale of the challenge is so great, where people will need sufficiently to be convinced that the improvements will lead to the sorts of productivity benefit that we've seen here in the southwest and in Bristol, and actually take out some of the capacity whilst that resource is whilst those improvements are happening. Because as long as we leave the capacity there, it will be used by other patients in order to release the resource to be able to move on and improve the next programme. That takes bravery. It's a challenging thing to do, but many chief execs are telling me that's the approach they're going to have to take.
Thank you. Just one other question. Yeah, please, come front.
Thank you. Andrew Valentin, a medical director of Bupa, an English private healthcare company. Thanks very much, Bernard. One of the biggest challenges I think we face is the clinical challenge of appropriateness of intervention. Yes. We hear a lot about unwarranted variation. And I'm just wondering whether you have been able to start on that sort of work with implementation of care pathways and actually getting the right treatment at the right time.
Yes, I didn't have time to talk about those aspects of our work this morning. As you know, Andrew and colleagues from England may know that Sir Muir Gray is leading the part of the national programme called Right Care. We've been involved in a number of different respects on this topic. We've worked in helping to develop and resource the development of some shared decision aids, a topic I know you know well, to help make sure in areas where there's clinical uncertainty that the patient's preferences are the dominant preferences in deciding what treatment takes place. In the States, where access rates are, of course, generally higher than ours, there's very compelling evidence that those approaches have reduced the use of high technology interventions. It remains to be seen whether with our lower current access rates the same impact will happen in the UK. The programmes that our benchmarks include looking at utilisation rates and helping organisations to see how their utilisation rates compare with others. And many of the contents of our work on high volume care are about trying to ensure that people are doing the right things and not doing unnecessary things in those care pathways.
Okay, Bernard, thank you very much.
You.
I think we change the stage now to the Dutch experience, and especially we want to know what kind of experience they have and what kind of evidence we have in the Netherlands that we really can cut costs and improve quality. Okay, Gert Westert.
Goedemorgen. That's the way to pronounce good morning. I'm really thrilled to meet so many colleagues in Amsterdam and talk about thorny issues with you. What I want to do, and with me, Barbara, we will give you an overview of what we are doing on this topic in the Netherlands. And I was quite impressed by our colleagues from England, their focusedness on the micro level, but also the way they work with productivity. And as you will notice during my talk, that our approach is a little bit more loose and a little bit more on the macro level. What I will talk about is a question from the Ministry of Health that last year that came to us, and they asked us if it's possible to save 200 million euros within the hospital sector and in projects that also improve quality. I will talk about that and how we use the evidence to find the right areas to save some money. And next to me, Barbara from the Netherlands Organization of Research Development, of Health Research and Development, will talk about the projects that they subsidize, the ZONMW, that's the acronym of the Netherlands Organization of Research, Health Research and Development, that gives a lot of subsidies to quality improvement projects. And within their team, they were thinking about how much money can we save by subsidizing these projects, and she will talk about that. Our presentation is divided into 4 parts. First, I will pay some attention to the urgency. Or can we wait? Is there a need to improve quality? Well, of course, there's always a need to improve quality, but do we need to save costs? Second, is there evidence to have the best of both worlds? And I will use the work by John Øvretveit, who couldn't make it today. Initially, he was in the program, but I was asked to take over from him. But I will use a lot of his work and also the work by Martin Marshall on the evidence behind this thorny issue. And then Barbara will take over about the Dutch initiatives, and she'll finish with the road ahead. But let's go back to the urgency. As you can see, this is this stacked bar histogram shows the evolution of cost of the Dutch healthcare system. Overall, we spent 80 billion, and that also includes the welfare part of the system. The upper part of the bars is the hospitals, and as you can see, we spent almost 20 billion a year on hospitals, and we were asked to come up with a smart list to save 200 million. The little green part of the bar is about general practice. It's only a very small part of the cost, but our general practitioners, they are gatekeepers of the system. And as we discussed yesterday about how the system works in the Netherlands, we also focused on the fact that the primary healthcare system is very important in guiding this whole topic on quality improvement and cost savings. And this is a combination of an international comparison of the cost in different countries, while we are right in the middle. Thinking about quality and cost, you want to be in this matrix on the right part, in the upper right part. You want to have evidence-based medicine. You want to have safe care for the patients. And of course, you also want to have shared decision-making. Well, we are not there. The orange star shows where we are somehow. We are our quality is quite good. There's a lot of variation, and the cost is on the international level quite average, but we want to move in the direction of the upper right cell. And the person who asked the question about unwarranted variation, I think that's a big issue, and I will show you some results from the Netherlands on that too. And I call that a little bit evidence-free medicine. What makes our care unsafe, ineffective and costly? Of course, there are adverse events and never events. And we had a big study a couple of years ago, and that the result of that was that almost 6% of all admissions there is somehow an adverse or a never event. And on an international scale, we are doing quite well compared to other countries. The band is between 3 and 17%. I was just talking about primary care, and our number of avoidable admissions, as you can see in this figure, the orange bars show avoidable admissions for asthma, COPD and chronic heart failure. You can see that the avoidable admissions in the Netherlands is quite low, and that's because we have a very strong primary care system. Compared to other European countries, there is room to improve, especially the Scandinavians do a pretty good job if it comes to avoidable admissions. And then an example, or some examples about unnecessary care shown in unwarranted practice variations. It's at all levels, and this figure shows the unplanned cesarean sections in low-risk women. The gynecologist, the group of gynecologists in the Netherlands, they came up with an indicator on low-risk pregnancies, and we made a display of all the 100 hospitals and showing the percentage of women that ended up with a cesarean section. And as you can see, the variation is huge between the various hospitals, between 7 and 30%. And actually, the public doesn't know about it. It's women don't know where to go if it comes to these type of figures. We don't have these data with hospitals named available in the country. So we have a lot to do in creating awareness of this medical practice variation. The Dutch Healthcare Performance Report, which can be downloaded from www.healthcareperformance.nl, shows a lot of examples of varying quality within our system. We have a pretty good adherence to guidelines by our general practitioners, but there is also a lot of variation at a surgery level, variation between general practitioners from 50% to 75%. On average, our 24-hour hip fracture moment is quite good, 80 to 85%, but the hospitals vary a lot, between 67 and 100%. Of course, we have the events with medical errors, pressure ulcers, and also in hospitals and in nursing homes. There is a lot of variation between the hospitals in the country. Wound infections vary a lot between hospitals, between 1.5% and 9%. And also there's the HSMR, also showing a lot of variation between hospitals. This slide shows the potential to save hospital days. And what we displayed here at specialty level is the band of variation across hospitals in length of stay. The trend is going down, and we came a long way if it comes to length of stay. We used to have very long stays in the country, but still there is an enormous potential to save extra days, and these figures are adjusted for case mix, quite sophisticated. So there's a lot to earn on that. And also prices, they vary quite a bit. this slide shows for 2 years in 2008 and for 2007 and 2008 the price for a hernia repair, and as you can see, the variation is between 1,000 euros and 2,500 euros. So that's a bit about figures about the Netherlands and the variation in quality within the hospital sector. And what we did to find low-hanging fruits, saving money and improving quality, we did a review of the literature. And there's quite a bit of reports around, the one by John Øvretveit, of course, by the Health Foundation. And recently there was a very interesting paper in the BMJ, Quality and Safety, by Martin Marshall and John Øvretveit, which gives a very nice overview of and the state of the art of things. I can recommend that to you. But also in the US there is various reports, and what we did is read it all, reviewed it, and came up with the summary list of areas where we can improve. And basically there's 5 big areas, and the first one is communication. All the reports that you read about quality improvement and saving cost, most of them talk about a lack of communication between providers or between providers and patients. There's a lot to do on that area in our fragmented and complex hospital and healthcare systems. A second one, which was a little bit of a surprise to me, because I wasn't aware of that, but rapid response teams are lacking in most of the systems. If there is a first signal of a patient's decline, you should have a rapid response team in place to take over, and most of the hospitals don't have that. So by having that around, you can improve quality quickly and avoid enormous costs. And of course there is the group of prevention, and we all know hospital infections, pressure ulcers, pneumonia and heart failure. These things happen within hospital, quite prevalent. Surgical complications, of course, and medical errors. So we used this list to come up with a list for the Netherlands and to save some money. And what we did, we used the benchmark within the country and extrapolated the figures for the rest of the hospitals. So for hospital infections, and that's basically saving hospital days by treating what is done in the best practice. You can save 30 million within our country. Drug errors is expected between 25 and 85 million. Having an acute medical unit or an emergency observation ward in a hospital can save 100 million, also because of avoiding delays of length of stay, but also for instance, for drug errors, you also avoid admissions and readmissions. And falls and pressure ulcers during admission can save another 20 million. Then the areas we didn't attach cost or cost savings to, that are also areas that we will focus on the years ahead, is adherence to guidelines. And not only adherence by doctors, but also compliance by patients, complying in using and taking their drugs. Last month there was an interesting paper in Health Affairs, an American study showing that improving compliance of patients using their drug is a cost-saving enterprise. So we can do and work a lot on that too. There's evidence. And of course avoidable readmissions and readmissions at the IC. Interprofessional communication is also a very important area. But are these low-hanging fruits and easy? Is it difficult to cash the money? And I have some messages to keep in mind. Of course, if it comes to quality improvement, it's also cost precede the benefits. And if it comes to cost effectiveness analysis, we should include the intervention cost. There's a lot of projects going on in the Netherlands, and there's a lot of investment done in that, but we are not used to include the intervention cost within the studies we do. And of course, it's already said by many others, implementation is the key. It's hard work, good ideas don't spread easily. And as our keynote speaker this morning said, we need a leadership. I think that's the key to implementation. If there's really leadership within a hospital, you really can make a difference. And also, and that's what impressed me about the presentation by the English colleagues, is that you need scientific evaluation to track barriers. You should have these quality improvement projects within hospitals at local level, but you should link them to scientific evaluation, and also to find out what the outcomes are, but also to track barriers at a very local level. Well, then one by Marshall and Øvretveit, clarify from the start where savings will accrue and to whom, and hold all stakeholders to account for realizing these savings. And then a thorny issue. Providers investing in quality improvement save money for others. Well, in our country, if a hospital invests in quality improvement and invests in savings, the insurer will cash the money. And arrangements should be made to clarify that. A difficult problem is, of course, long-term effects of prevention. And from the beginning of quality improvement projects, it's important to understand that scale up is not just an afterthought. You should be aware of that at the beginning. And a final thing I wanted to address, and also for the Netherlands that's important, stop paying for adverse events. In our country, if something nasty happens within a hospital, for instance a pneumonia or a central line infection, you can easily open a new DRG, treat the patient and get the money. As we heard yesterday from Helen Bevan at Dutch Experience Day, talking about the two systems. In England, they have now the rule that after 30 days being in the hospital and something happens afterwards, the hospital is held accountable for the care that is provided and the aftercare and what is needed. And also that could be applied to events and never events, adverse events. Well, for sake of time, I will skip this one, and I'd like to hand over now to Barbara to tell about her experiences by ZONMW in the Netherlands. Barbara?
Good morning, ladies and gentlemen. We've heard a lot about the evidence for quality combined with cost saving, and I'm from ZONMW, which is a co-host of this conference, and I want to welcome you to Holland, and I want to tell you a bit about our experiences in using the combination of quality and cost saving. John Øvretveit was originally going to do this presentation with me based on his work for the Health Foundation, and the evidence that he presented was in the same line as that Geert Westert has presented, and also from our English colleagues, that there is evidence for potential cost saving, and especially in the areas of reducing accidents and adverse events, and reducing the use of ineffective treatments. And if he was here today, he would go into this evidence much more, but I want to just start with this beginning, because we're working with this evidence in our initiative that we took as ZONMW. Geert mentioned it also. The reaching cost saving is the problem, because a lot of times the cost of the implementation is not included in the cost saving, so it depends how much it costs to implement. And also you mentioned that to reach cost saving you need to invest, and the beneficiary is often at a different place. And this is what we're seeing in our experience too, and we're trying to deal with. But you may ask, what is ZONMW doing with cost saving and quality? We're like a health research council. So we commission research in 80 programs, but from the beginning of ZONMW we've also had the ambition of not only commissioning research and making sure that there are good research is being done, but also to look for bridging the gap between the knowledge, science and practice. And for 10 years now we've been doing active implementation policy, and actually from this ambition comes the driver for us as an organization to work on how to use cost saving as a driver for improving quality. I always say the costs are one thing, but I want better quality, and I want to use this urgency of saving costs, which is rising, and we've heard in the previous presentations all about that. We're going to hear more about this and feel it more in the next few years, and I want to use this as a driver to improve quality, and we think that it's possible. From our programs, we continuously receive results of proven cost effectiveness, and this goes on and on. So we want to use this evidence to make a difference in practice. But, and it's been said before, and it's been going to be said the whole conference through, implementation is the key, and implementation doesn't go by itself. So implementation needs to be actively promoted, and this is one of the examples of what we're doing. Just to give you an example of what we get research results back, and one example is that proven is that x-rays for gastrointestinal x-rays have no extra diagnostic value when people come to the emergency department with acute intestinal problems. You need ultrasound and possibly a CT scan. You must know how many GI x-rays there still are being made every day in hospitals all around the world. But the evidence shows that per 1,000 of these patients you can save 100,000 euros. Why isn't it getting done? We see the implementation rate is slow. In the Netherlands, this evidence is now being put in a guideline, so we take a few years to make the guideline, and slowly, I think the practice of using these x-rays will fade out. What we want to do is quicken it along a little bit. How have we been busy with this? In July, we got also a question from the ministry. Do we have any cost-saving projects? Because they were working on where can we cut back. And we looked at our projects. We have about 3,000 either finished or running projects in all these programs. And a very quick scan, I'm not saying there's not more, but anyway, we found in a short time 100 projects where there was, at least in one location, in one project, in one setting, a proven link between quality improvement, or at least not deterioration of quality, and saving of costs. And in total, I didn't want to put it on a sheet, but I'll tell you, if you count it all up, we came to figures of about 300 million euros that we could save from all these projects. What we wanted to do as an organization is not only send out the report. I have it with me here. You can pick a copy up in the Dutch corner later on. It's translated into English, the summary of this report about the 100 projects. And we could have just sent it out and said, have fun with saving the money. But we thought, no, we want to bring it a step further. And what I want to tell you about our approach, which is a little different than the English approach, which is much larger scale and much more national. But we started on a small scale. And we made a call on a weblog from our director asking for potential pilot locations. But just to get back to the quick scan, what were the main results? Yes, quality improvement can be combined with cost saving. Cost saving doesn't mean per se cutting back in quality. And if you look at all these projects, in every sector, prevention, cure, long-term care, we found examples of that you can combine these two. What we did also see is that there's a wide range of methods for determining the cost effectiveness. So comparisons between projects is difficult. This is a more methodological question, which we're starting to address in ZONMW in the coming time. And what we said and what we found also is that a lot of times the cost and the effort needed for implementation is not described very clearly, so we need more information about that. But that's what we got out of the quick scan. And if you look per sector, you see that next to all these examples that we've already been heard, we found a lot of new diagnostic methods and new treatments which give better care and save money. I'll give you an example in a minute. In long-term care, we found that most of the cost saving can be found in labor saving. Much of the cost of long-term care is, of course, cost for personnel. And in the area of labor saving, the urgency will grow, as you know, in the couple of years to come. So even if it's not about money, saving labor is an important issue, and you can do a lot on that. And a lot of saving, not on high-tech, new, new innovations. ADL care, washing, meals, medication. In all these areas, you can save time of personnel and therefore money. And we found a number of examples in home care of domotics. I don't know if that word is correct. Technologies which you can use in the home to save visits and to have communication with patients at a distance. In prevention, we found examples of potential cost saving, but here as the most is clear that if you invest in prevention, you're going to gain in curative care. And who's going to make these investments? So, we set some ambitions for our organization for the next 2 years. We want to bring the implementation of these cost-saving projects a step further, and we want to build the sense of urgency in Holland that cost-saving is necessary and that you can do it without what Bernard said, cutting and crude kind of cutbacks. And we want more cost-saving data to be generated in the next few years and to be built into our working methods when commissioning new research. This quick scan is continuously being updated because continuously we get new results from new projects, so we're not going to do a yearly report but continuously add in our database new projects which are available online, unfortunately still in Dutch, but we're working on translating interesting stuff for you. What we all want to do is to include more information about implementation and get more of the experiences that people have had while doing these projects already. Most of the time you just have to go and ask them, but they don't write it up in their scientific reports. So we want to build on the information of how to implement these projects. And another interesting issue, what we want to learn more about, and I think it would be interesting to discuss with you, I think that one of the best implementation strategies is de-implementation of the old stuff. If the old way is still being financed and still being allowed to happen, why try something new? So we're working on methods to, if you're introducing something new, taking the old actively out. And I think that would be interesting to talk with you if you have experiences with doing that. And the second, what we do is not only working on bringing out knowledge, but working with front leaders in achieving quality and cost saving. So we said we can make a small contribution, and we called up for leaders that want to join with us in achieving the cost saving. We make a contract with them, and we put in the contract what ambitions do you have in money that you want to save. In the contract is also written up which interventions, preferably from our quick scan, which ones are you going to use, and what kind of support do you need from us or arranged by us to get it done. And we made available an amount of money of maximum support in the worth of 25,000 euros, which is not much money for a hospital, but it's interesting to see that people are interested in joining this movement and being a front leader, taking the challenge and wanting to show that it can be done. The support needed we arrange in a project group, and what we see is that people are asking for support on measurement and asking for support about what is the content of this new intervention that we want to do. And it interesting is that they don't really ask much project support like project management, or they seem to think they can do it themselves, which is interesting because I think we've got some change management competences in the system now, and people are not asking us for that kind of support. And the last thing that we're doing is doing an online community, because the locations that we have, there are now 6 in long-term care. We're looking still for 2 in prevention and 2 in hospital care. The idea is that they share their experiences in getting their projects done, and talking about what they are doing and what their points are that they head into, and that they share this information in an online community. And it looks like this. You can join up with a LinkedIn account, and you can read all kinds of examples. All the projects are written up there. You can meet with people who are doing cost-saving projects. You can have a dialogue. We have a Twitter account that says a lot about new reports and information about cost-saving. And I'll tell you a little bit about how it's going. The interesting thing is that we have now 6 locations, and they're all long-term care organizations. So in one way, it could be that in long-term care, the urgency of having to save costs is maybe higher as yet than in hospitals. We haven't been seeing the cutbacks yet that we expected. But what we see is that they're choosing examples like this to do. There's one home care organization that is joining us, and they have a new way of bandaging pressure ulcers, and they say, ulcus crurus, the wounds in the legs, they say that they can reduce the healing time from average 1 to 2 years back to 6 to 8 weeks with this new way of bandaging. But you need to train specialized nurses to do this, and that costs an investment for them to train 10 nurses of 89,000 euros, and they projected that by shortening the time, and can you imagine that you're shortening the time that a patient has a terrible wound? I mean, so that's a thing that you want to do anyway, and then they say that you can save 7,200 euros with that. So even if you just do 10 or 15 patients, you've already returned on investment, but you need to make the investment. Second example is washing without water. We have a lot of data that shows that if you use a special cloths which don't need water, that you can save 9 minutes of washing time per patient, and the data shows in the evidence that patients like it, the nurses like it, and they can use the time to be together with the patient, or they can use the time for other patients. So one nursing home is starting to do this, and this will be also the first time that they try it in a home care situation. So we're supporting trying this new way of washing in home care. What have we seen until now? We see that long-term care is willing to join in, and that it's harder to find hospitals or locations for preventive care, and that the process of making agreements, what are you going to do, what support do you need, and what kind of cost do you want to save, it's not that easy. You need to talk a lot with each other, and even in these frontline organizations, the people they have to be coached into making concrete agreements. The community is developing. We're having a lot of visitors to the community, not that much interaction yet. Everybody's going about Web 2.0, but there's a lot of consumers we've seen, which is not a bad thing, but it's interesting to try this new way of sharing information. This last slide may help for the discussion also, because this is the areas where we think that we want to go in this. First, we want to achieve the cost saving. Then we want to go into making deals with insurers that are going to reap the benefits to do the investments needed, and then they can use the evidence that we as a research organization provide. And the interesting part of making cost savings in curative care through investment in prevention. And I would really like to prove that de-implementation is a successful strategy for implementation. So I hope to come back next year and tell you if it's working. And I'd like to discuss with you your experiences in this area. Thank you very much.
Okay, thank you, Barbara. Thank you, Gert. We are a little bit running out of time because it's in about 8 minutes the next plenary will start, and I see people coming in from the backside. Is there some burning question you want to ask? Okay, well, let me tell you. This morning it was in the papers that an insurance company, a healthcare insurance company, made a new contract with a hospital in the northern part of the country. And it is a 5 years contract, and that's very special because those contracts are normally made for 1 year. And they promised, in that contract, the hospital promised to save 7% of their budget. And if they will succeed in that they will be rewarded by the insurance company if they will succeed. So what you see there in that hospital, and I know the CEO of that hospital is here in the conference, that he trusts himself and he trusts his people that he is able to save 7% in the next 5 years. So, and he trusts himself that by quality improvement and by improving safety, he can save 7%. And the agreement is that it has to be done by quality improvement and improvement safety. And he has to show that to the insurance company. And what you see here is that these kind of possibilities we saw from the NHS and we saw from the Netherlands. You need some, thank you. You need some external pressure, incentive to make it true. And I think in the National Health Service, that pressure comes from you, David. Bernard, I think. And in the Netherlands, we have our insurance company who do it, and the government is pressured. Let we take the opportunity that we know how to do it, and that we stop just cutting costs, but that we do it by improving quality and safety. Okay, we stop now and we invite all the people to come in for the next plenary. Thank you for the presenters. Thank you for the lessons you learned to us.